Hello, y'all. I just heard Prof Rez, who I'm gonna get to see in the next couple of days in real life. I'm gonna give him a big hug, and I'm working on developing the physical capacity to actually wrap my hands around him because he's so massive by eating this delicious chocolate throughout the course of this hour. But I just heard that Prof Rez is coming bearing gifts, which actually kind of makes me feel complicated. I'm both very grateful for Prof Rez and his gift, but also now feel horrible that I didn't think to do the same.
Can I interject? How did you take the word of gift and pluralize it?
Oh,
J-
oh,
I said
oh,
gift. I didn't say gifts.
oh,
I'm
oh
not
no.
Santa Claus, man.
Oh
Even
my
though we
God.
passed Santa Claus Lane during our journey.
Oh, really?
Yeah, we did. And by the way, you shouldn't give me a gift. We're visiting you guys. We have to be the gift bearer.
That's right. That's
Kashayar knows this. As Persians, we give gifts.
did,
Soon all the non-Persian people are going to
did
stop
you
listening
just
to the VMR.
did you just listen to yourself? You said Persian people give what?
Oh, gift.
No. You said gifts. I look forward to it, Prof. Rez. Anyway, it's a chaotic start to Friday in large part because I think we're a little bit giddy. We have the one and only Dr. Ravi Singh presenting a case after I would say years. So before we hand the mic to Ravi to say hello, I'd love to share some love with our scribe and our teaching points crew. So in the scribing role, Zachariah, do you want to say hi? Tell us where you are and how your day has been.
Hello, everyone. I'm Zakaria from Cape Town, South Africa, and looking forward to my third time scribing. Had a nice quiet day and having a weekend off. So yeah, happy to be here.
Amazing. If you all are joining Friday VMRs on the sooner end and missed last week's case, you will recognize the scribe as the former case presenter who really shared a very powerful personal case that I highly recommend you check out if you haven't already. And Teaching Points is actually, I should say this publicly. Elena, who's doing the Teaching Points, is one of our newest VMR leaders, which I think captures just how pivotal Elena has become in a very short period of time to VMR. So I'll pass the mic to you, Elena, to say a quick hello.
Hi, everyone. It's great to see you. I'm Elena. I'm from Germany. I'm right now in Switzerland at a friend's place doing the Teaching Points today. Yeah, I'm super excited for this case. And yeah.
Where are you, in Zurich?
No, but it's kind of close. It's like 1 hour from here.
Because
My
that's the
friend.
German-speaking part of Switzerland, Robbie. Genève is the French-speaking part. And then south or north is the Italian-speaking part.
Prof. Rez, I thought you were gonna save your magic for Aliquot 1, Prof. Rez. Hold it in, hold it in.
It's a southern part, yeah.
Last but not least, I think Ravi's probably too humble to share this with you, but he is now the interim program director of his did you know Prof. Rez? Yeah, he's too humble. Ravi, can you I think humility's out the window today. Can you share with us the career and life update that you have? I think everybody here will be very thrilled for you.
Yeah, I stepped into the PD role because our former PD, if you remember Dr. Stephanie Sharp, she's moved on to the associate dean because we have a regional medical campus of George Washington University here, so that required her services. So, but she's still around. I am glad we do have some CP Solvers Academy members with us. We've had Franco, we have Gia just reached here 2 weeks ago, and both of them are flourishing. And I'm excited for the new interview year for next year, Match 2025. See what it has in store for all of us.
I really hope all of you will just think of the possibility of potentially matching and learning under Ravi. It's been an absolute gem and VMR legend for many years now. And we're all so grateful for you, Ravi. I think that every enterprise has an unsung hero, and I think you're definitely that for CP Solvers. And so I think we should try to sing your name louder and louder. But I always get anxious doing it because I think Ravi's just so shy and so humble. But I'll power through that. But thank you again for the case today, and we'll hear Prof. Rez's magic in the first Aliquot.
Oh, awesome! So I'm going to channel my inner Kirtan and give you a title. I put part of the case into ChatGPT and asked it, What would you give this case a title? And it came back with breathless and baffled, which we truly were. So we'll start off with the first aliquot. We have a 49-year-old male who was feeling bad, rather nervous, shaking, clammy, short of breath, and was immediately put on high flow oxygen in the emergency room when we went to see him. And I'll stop there for the first part of the discussion.
Well, Ravi, this is an exciting start. Congratulations to you on being the interim program director. And I wish I could reapply for residency so I could come train under your guidance and supervision. It's a really robust start to the case. And I think GPT did such a clever job of titling it because it not only represents what the patient is experiencing, but also represents what the providers are experiencing. And I will say, when I look at this, we got a bunch of words there as part of the chief concern. The feeling bad, the nervous, the clammy, the short of breath, put on oxygen. You can imagine that someone with these symptoms, take out the put on oxygen, what does it sound like? It really sounds like a panic attack. Like someone is having a catecholamine surge, is activating their sympathetic nervous system, and therefore is seeing the sequela of that, which includes, you know, a little bit of diaphoresis, anxiety, and this sense of doom. And that's what this patient's telling us. But all that suddenly changed was put on high flow oxygen. Because if you're having a panic attack, you really shouldn't require any oxygen whatsoever, unless it's so severe and it ends on the spectrum of stress-induced cardiomyopathy, and then you have pulmonary edema requiring oxygen therapy. So all of a sudden, the story becomes, why is the patient hypoxemic? And can we use the other symptoms to try to make progress on that? And maybe I'll be very, straight shooting here rather than give a broad DDX and then pass the mic to Robbie to see what else he'd like to layer on. But I would say that if I'm using the constellation of symptoms, which quite frankly, I wouldn't be using, I would just be focusing on the hypoxemia, all of a sudden stuff like thyrotoxicosis comes to mind with an impact on the cardiovascular system. The anxiety, the tremors, the diaphoresis, pheochromocytoma comes to mind with just a catecholamine surge. These are all such rare diagnoses, and there's a good chance, and honestly, probably a more practical approach is to say, look, someone when they're hypoxemic and they're suffocating, they're going to have a sense of doom. They're going to have anxiety. They are going to sweat. Think about it. So then the approach just becomes hypoxemia, which I will pass to Robbie to maybe share an overview about.
I love that, Prof. Rez. It was so cool to hear you say all the other things that this could represent. And then ultimately, I didn't make this realization, but it's such a practical one. This person is really, really sick. And just from being really sick for any reason, you could be hypervigilant and alert. I love that. And so it's very possible that this problem might just simplify to hypoxemia, but I think we have to, as you said, keep our eyes open. So, but to really just focus on the hypoxemia, I think that the first thing to try to do in this patient when they're requiring high flow oxygenation is to really realize, is the patient truly hypoxemic? So a quick glance at the waveform will help you a lot. And what the waveform is basically the idea that if you're using a pulse ox and measuring the pulse ox by putting it on the finger, the signal should come and go just like the systole and diastole of the heartbeat. So if, for example, your patient has significant nail polish on and the signal that is making it to the detector is not oscillating like the heartbeat, you know that that's because there's something in the way. So many patients who are critically ill, who are clamped down because their sympathetic tone, as Prof. Rez already alluded to, is you always want to make sure it's a problem that's really real. I think that the influence of what the patient looks like is a powerful one. And a patient who is short of breath, the probability of that oxygen saturation being real is much higher than when a patient's looking comfortable and isn't. So I would confirm in real life and look and hope to see that the waveform is oscillating. And by the way, for fancy pulse oximeters, they actually give you a number as to the correlation of the O2 sat with a waveform pattern. And so the closer that number is to 1, the more likely that the O2 sat is real. And so this immediately becomes a question of trying to localize the lesion with hypoxemia. And the lesion exists in one of 2 places. Is there something wrong with the alveolus? Or is there something wrong with the blood vessel that is meant to receive oxygen from said alveolus? The alveolar problems tend to be either filling issues or collapse. The vascular problems tend to either be that the patient has shunting physiology from a very distant blood vessel, or that the blood vessel is blocked. Very rarely, there might be blood problems that cause a false hypoxemia, such as methemoglobinemia. So I think the progress that you can make with this patient is actually very simple. If you listen to them very quickly and you hear any sounds, crackles or whatnot, the probability of it being an alveolar problem is pretty high. If there is relative silence compared to what you are thinking of, then the probability of a vascular problem is pretty high. Another clue to a vascular problem is disproportionate hemodynamic symptoms or findings. This is why we say that the patient with a pulmonary embolism has both tachycardia and hypoxemia. And that's a reminder that almost all vascular problems come with a disproportionate hemodynamic fingerprint. So in lieu of the clue of music suggesting alveolar disease, the clue for vascular disease tends to be a hemodynamic fingerprint. So with very simple glance at the monitor, if there is disproportionate sinus tachycardia or disproportionate hypotension, vascular diseases start to rise up. If there is relative sparing of those things with music on the chest, then an alveolar process starts to play. So you can make tremendous progress in the first minute or 2, not knowing what the answer is, but having a suspicion as to where the problem is in the alveolus or the vessels, with the key clues, again, are music for the alveolus and a hemodynamic fingerprint for the vessels. These are clues, not confirmation. So I'm eager to hear what Ravi has next in the story.
Great discussion so far. Just moving on to as a sequence of events unfurled. So some history about this patient. He has a history of anxiety and prior splenectomy. He was not able to give us this history, but we were able to ascertain this from the medical record. So he had a splenectomy due to a motor vehicle accident 20 years ago. And now with this presentation, he's short of breath. He apparently was short of breath 4 days before this. And as he progressed in the emergency room, he ended up being intubated. And a previous hospitalization mentioned a episode of alcohol withdrawal in the past. And I'll stop there.
Yeah, I think, Professor, maybe I can just comment on everything else except the splenectomy and leave that to you. We have, if we have a mental model of excessive sympathetic tone being a very simplistic one, that either the excessive sympathetic tone is from an exogenous process, such as a substance like cocaine, or withdrawal of a substance like alcohol, and an endogenous process, meaning that the catecholamines are coming from the inside. I think we get a hit for both those possibilities in this circumstance. And the hit would be that the patient has had alcohol withdrawal and is having recurrent alcohol withdrawal, and that the patient has anxiety and maybe potentially having recurrent anxiety. And I think what it does for me is that it opens up the door that there are 2 separate explanations for the problems we're seeing. That the sympathetic surge has 2 ready explanations. Is this person now having a sympathetic surge because he's anxious and that's how his disease manifests? And is this person having a sympathetic surge because of a separate illness? He consumes a large amount of alcohol and stopped because he was ill. I think we really should just emphasize how much diseases can be camouflaged by patients seemingly unrelated but important relevant conditions. And what do I mean by that? I think even a patient's personality type and resilience and social cultural skills, social cultural environment influences how they present their disease to you. And a patient who has anxiety at baseline is much more likely to experience a very different set of constellation of symptoms than somebody who doesn't have that comorbid condition presenting with the same separate independent diagnosis. And so I think that the probability of a new sympathetic storm physiology becomes much, much lower when you have two ready explanations for it. One of them, anxiety, doesn't have any acute bearing on the medical consequences right now of what the patient could have, but the alcohol withdrawal not only opens the door to suffering from consequences of alcohol withdrawal, but opens the door to a myriad of consequences in the lungs, in the heart, or other places that can occur from excessive alcohol use. So to summarize, the sympathetic storm dimensions that Prof. Reza alluded to have two ready explanations, reducing the need to search for an additional one with vigor. One of them, namely the alcohol withdrawal, comes in keeping with excessive alcohol use, which will certainly color the presentation now. And it wouldn't be far from conjecture to wonder if the remote motor vehicle accident was potentially even related to alcohol itself, just speculating on how severe the alcohol use may be and the myriad of consequences that the patient may be at risk of in this presentation. So I'm definitely latching onto that a lot. Any other thoughts on that, Prof. Raz, or the splenectomy?
No, I think that's a fabulous approach. And with regard to the splenectomy, quite frankly, at time point 0, I wouldn't really, put too much cognitive effort into it. But just for teaching purposes, because it might be relevant for someone in the future, the spleen is heavily involved in our immunologic system. Specifically, it helps target organisms that are encapsulated, because once those organisms are opsonized with an immunoglobulin, the spleen then removes them. So if you don't have a spleen, you're at risk of these encapsulated organisms like S. pneumo, like Neisseria, like H. flu. And then the question becomes, does a splenectomy confer the risk of bacterial pneumonia? And is this consistent with this patient's presentation? Ordinarily, if this was just one day of shortness of breath, I would say no, it's just too fast. But because Ravi told us this started 4 days ago, you can easily imagine a scenario where someone has a community-acquired pneumonia that then blossoms into acute respiratory distress syndrome. So that's one way you might be able to link the splenectomy to the shortness of breath and pulmonary findings. Another more immediate complication of splenectomy is portal vein thrombosis, or thrombosis where in the region where you remove the spleen. That's actually quite common. And I think Rob B, we had an RLR episode where we talked about this and what to do about that, whether to treat or not. And I think it's common enough, and I don't know what the literature suggests there. But the other thing this does for me is that because the spleen is removed, all of a sudden the baseline, like platelet count, it's going to be higher. So no longer can I use the platelet count as a surrogate of chronic inflammation. And then the final thing is, I think there's a slightly higher increased risk of thrombosis beyond the portal vein because of the higher platelet count that is associated with spleen removal. So I think all this does for me is just say, hey, like he's immunocompromised. And yeah, that's pretty much it. But beyond that, not much. Back to you, Ravi.
Okay, great. Yeah, that was a great point about the platelets and the spleen. So Let's dive into the exam. So notable features about the exam, I'm just going to mention that the temperature is 37.7, heart rate 117, respiratory rate 26, blood pressure 152/101, and pulse ox 94%. Now, he was on high flow, then he progressed to a ventilator because of the severe agitation, and then suspicion of alcohol withdrawal and requiring a Precedex drip. So major findings on the exam: his lungs, he had crackles at the bases, and he had this rash on the left thigh that was sort of flat, and he was sort of reddish. And I'll stop there.
All right, this is really helpful. And of course, in someone who is experiencing severe alcohol withdrawal, we tend to sedate them. And especially when they have complications of seizures, DTs, sometimes you actually have to use a Precedex drip. But the important thing here is to realize that this patient was intubated before being sedated. So I don't think the issue here is alcohol withdrawal. The issue here is what's happening in those lungs. And I will also say this, that patients who are intubated and ventilated, it's really hard to do a good lung and cardiac exam. I mean, I haven't been in the ICU for years, but I remember as a resident, you really rely on the imaging and the ancillary tests that we receive. So, you know, Rabih said in the first aliquot, he's going to want to know, do the lungs sing or not, to push us towards an alveolar process. I would say even here, though there's nothing noted, it doesn't exclude at all the possibility that we get an X-ray and there's multiple opacifications in both lung fields. And it is actually quite telling that this patient's O2 says only 94% despite being intubated, despite, you know, 100% oxygen being delivered directly to those alveoli. So I would be shocked if this is not a, and honestly, I'm leaning towards an alveolar process, because if you think about it with PEs, like, yeah, there's some hypoxia, but to get to the point where someone needs to be intubated, PEs, as Rabih said, usually has that hemodynamic signature, not the respiratory signature. And shunting, yeah, it doesn't respond, but boy, I've never seen someone with a shunt present so dramatically. Mind you, I haven't seen many patients with shunt, but right now I'm really focused on the alveolar process, and I'm really waiting for that imaging. What the vital signs say, and I'll leave the rash for Rabih to talk about, sucker. But what the vital signs say is that it's exactly what Rabih had mentioned, and what we had actually concluded in aliquot 1. There's a huge sympathetic surge here. The tachycardia, and the tachycardia is coming with hypertension in someone who's sedated, which speaks volume to the amount of catecholamines that are in this system. And then the question becomes, is it appropriate catecholamines or is it inappropriate? Appropriate being if someone is hypoxemic, is suffocating, they should have this catecholamine surge. And again, it takes you away from like the cardiovascular system necessarily being the culprit, especially in someone without a history of heart failure. So all I gather from this physical exam is I can't take off the alveolar process. I'm actually leaning towards an alveolar process, and that there is a huge catecholamine surge, probably appropriate based on all the events we have, but that's yet to be determined. And then I'll pass it to Rabih. I probably wouldn't have even noticed the rash, so it's only right that you discuss this rash that Rabih picked up. Guys, this is getting so confusing. Rabih, I have to like emphasize the last two letters.
I love that, Prof. Reza. I love the conclusion that you're coming to. Basically, based on the severe hypoxemia, you're very worried about an alveolar process. And I think that I don't know what to do with the rash, because a very simplistic approach to a rash would be to wonder, is it an outside job, meaning that there's something on the outside like an irritant or a contact, or is it an inside job, meaning that there's something coming in from other parts of the body, such as a disseminated infection? And in general, a very simplistic way to say is whenever you have a unilateral rash in one very specific concrete location, it tends to be an outside job. local cellulitis from staph infiltrating the skin, contact dermatitis. And so I think for me, I would probably not be making much of a rash because much of a big deal of the rash because its fingerprints are so far that of an outside job. And an outside job would be less relevant than the inside job that the lungs are seeming to signify here, especially since the lungs seem to be bilaterally involved. So I think the question as a thought exercise would be, what would the characteristics of the rash be that would make us bypass this general rule? And I think it would have to be depth. So the rash would have to signify its real deepness to catch our attention. And so what would examples be to be more clear? If the rash were ulcerative, if the rash were nodular, if the rash were vascular in the form of livedo reticularis, livedo racemosa, or purpuric in nature, I think that kind of rash would get our attention. There are some very, very deadly skin-lung disease combinations that you probably should be primed for only in very specific circumstances. And the reason that my mind is primed for it is not because it's probable, is because one recent NEJM case actually had this example of a young woman who had a deadly skin-lung combo. And so that it triggered that reflex. So, but I don't think I would think about it in real life now, but know that there are examples of that. And I'll throw out a non-answer to that, not to ruin anyone's NEJM case, but melioidosis is a classic example. If this person were in Southeast Asia and they had a skin-lung problem, that would be actually a very common presentation of a very common infection there. But in real life, my two thoughts would be, oh, it's just on one leg in the face of a systemic syndrome, probably a distractor, but let me look at it closely to make sure it's not deep, nodular, ulcerative, or vascular. And if it's not any of those things, I would probably not use it to my advantage and ignore it until it either became obvious it was relevant or became even more and more likely that it was irrelevant.
Can I just say one thing? That's awesome. Once again, I didn't know that we had crackles on this exam, but I'm actually happy I didn't see the crackle. I was talking as if there were no crackles because it just tells you like it's hard, right, to auscultate. And with all the other information, we arrive at crackles, which ultimately is water, pus, 95% of the time, and less commonly blood, protein, and cancer cells.
Hey, Reza, can I interpret that with a little bit less humility? What Reza was trying to say is he can tell you what the exam is going to be even before you present it to him. And if it's different than what you said, he said it would be, then you're wrong, and that he would have heard crackles. So yeah. That's my gift to you, Prof. Rez. Shower you with a little bit of ego boosting there. What do you have next, Ravi?
I have imaging and labs, so I'll put them in the chat so the scribe can actually access them. So notable labs, proBNP 1730, sodium 130, bicarb 17, BUN 32, creatinine 1.4, glucose 307, anion gap 16, albumin 2.6, ALP 137, AST and ALT is interesting, 100 and ALT 38, total bili 2. And then for CBC, white count 14.5, hemoglobin 14.4. Platelets were 117 and on repeat actually dropped to 43. Neutrophils 86%, lactate 5.6. COVID, flu, viral panel. Some people asking in the chat was negative. CRP was 320. And regarding the imaging, so I have a X-ray and a CT. So the X-ray showed interstitial thickening bilaterally, which suggests vascular congestion or pulmonary infection. And the CT, I'll put both of these in the chat too, showed infiltrates, peripherally, suggesting pneumonia or aspiration. And there's a 4.8 centimeter soft tissue density with partial rim calcification in the left upper quadrant. And I'll stop there for discussion.
Professor, maybe I can just tackle the labs and I'll pass the imaging to you. I think the labs are very, very alarming. This patient is very sick, as evidenced by the deep thrombocytopenia and high lactate. I think when somebody has thrombocytopenia, we often have a checklist of deadly things, like thrombotic microangiopathies as an example. But I think when somebody is this systemically ill and the center of gravity is not hematologic, it often is just a marker of severe inflammation, such as that in keeping with an infection. And so I think I would probably right now make sure that the patient didn't have schistocytes, but use the thrombocytopenia to signify that the patient is very, very ill. And I think if we go back to Prof. Rez's model of, okay, we have infiltrates in the chest. What are they? Are they blood, pus, or water? I think that this is a great example of there being a tremendous amount of evidence that it might be both. And let me try to make that case. When you have a patient who has a pulmonary infiltrate, a high white count, and a high lactate, the default hypothesis should be that this patient has pus. And it's always really important to make sure that the pus that you are invoking actually originated in the lung. For a brief second, especially for somebody so ill, you should wonder whether the infection is cardiogenic and the lungs are as a reflection of water filling the lungs from an infected heart. And I think we learned that lesson and we're emphasized that lesson on an RLR presented by somebody not quite directly Kirtan, but his chief resident over at Cook County. And so I think when you have a signature of infection that seems to be centered in the lung, but then the lungs are telling you to look at the heart, you can connect those dots by saying there's a pulmonary infection that has caused a stress cardiomyopathy or a septic cardiomyopathy, or that the patient has pre-existing heart failure and isn't handling that infection very well. So the infection lives in the heart, but the heart isn't healthy enough to cope with it right now, or that the infection lives in the blood all along and is radiating its consequences into the lungs. And so in some ways, the question is this a hyperacute lung problem or is this a hyperacute cardiac problem? And I think in these instances, the role of the BNP is very, very powerful. And I think here pushes us to think very quickly about a cardiac issue. And if we were to make a checklist of really severe cardiac issues that we must diagnose on in the first hour or two, it's course acute myocardial infarction with an EKG and a troponin. It's a rapidly progressive pericardial effusion or endocarditis. And I think I would be very, very concerned based on the border low-grade fever, not quite a fever, but it's hinting at it, 37.7, lactate, white count, BNP, that I would empirically treat this patient, not just for community-acquired pneumonia, but for infective endocarditis until proven otherwise. And I think I would be on the phone desperately with the cardiology fellow to do a bedside echocardiography in the first hour of this patient's illness, because I think it could be very, very deadly to miss it otherwise. Yeah, I think the labs are very, very alarming, and my single most important test right now is a transthoracic echo based on that localization. Curious what you think, Prof. Rez.
I really loved how you just simplified it to, is this a hyperacute heart problem or a hyperacute lung problem? And then saying, well, it could be a bit of both, but I'm gonna put my money more on the heart than the lung. And I'm right there with you. I really am, because of the way the CT and X-ray are showing interstitial infiltrates, which is sounding like edema. And even the radiologist goes on to say it's appearing like vascular congestion. But the echo would be so helpful to help distinguish that. And also a troponin, because if we are worried about a myocardial process, that could be quite telling. And what do we do with this mass that's found in the left upper quadrant? Honestly, I'll tell you my punchline. I'm almost approaching it like the rash that Robbie noticed on the left leg, meaning I'm tracking it, but I'm putting it more as a distractor than a signal. And I'll explain why. In real time, knowing that this patient had a splenectomy, I'd be very curious to know, is this what we would expect to see after you remove someone's spleen? Some calcification? And then a very simple approach. Anytime I see a mass, is it a neoplasm that's either benign or malignant? But I can't think of any neoplastic process that would present so robustly with such a pulmonary manifestation. Is it an infection? In an infection, it can be an abscess, or the calcification makes you think of granulomas, like a granulomatous infection, but why would it just be in the left upper quadrant and we're not getting much signal in the lung? And then less commonly autoimmune, where you can get an aggregate of cells, for example, sarcoid, IgG4 related disease. So that's like a simple approach whenever you see a mass, but it's hard for me to connect the left upper quadrant to the lung at this point. So I'm putting it aside, though I'm tracking it. And I'll just make one final comment. The thrombocytopenia, if this patient had a spleen, we would say, wow, that's pretty impressive. But with the spleen removed and being that low, it is very impressive. So how we primed our mind in aliquot 2 that what are some of the complications or expectations after a spleen is removed? It's a platelet count, I think in the 500 to 600. I'm just speculating there, but it's definitely something that will show up high. So this, Robbie, I feel like this platelet count, probably at time point 0, you would say, is this DIC? The hemoglobin is up, but we really got to rule out hemolysis. So that peripheral smear, I believe, is going to be very helpful, unless it's just a bystander to this rip-roaring infection that we've yet to diagnose. Any thoughts on that before we pass it back to Ravi?
I completely overlooked that. I think that's an amazing point. And yeah, the delta from what we expected is extreme. And so I think we should probably scrutinize it even more. I think that's a really, really good point, Prof. All right, what you got next, Ravi?
Okay, so this is all happening in the span of hours. So his wife arrives and she provides some really important information, which actually will shed some light on this case. So she says that her husband, on a past holiday weekend, he had gone shooting and camping for a week around the Shenandoah Valley. And after returning, he was not feeling himself. He kept complaining he was having a fever. He was warm. He got better within a few days, and he decides to take a trip to Florida to see relatives. And he was feeling okay, but there were no fevers. And then again, he went into a cycle of fevers and then complaining of fatigue and also complaining of muscle aches and pains and malaise. And this was trying to remember which part of Florida, Sarasota, Florida, I think. When he returned back a day later, he then came into the emergency room, and all of this then happened. And I'll stop there.
Boy, I'll get the conversation started, but I'm really gonna love hearing Robbie put the arrow in the target, and so whatever the saying goes. But this is so helpful, Robbie, because now we have a person with certain travel history presenting with cardiovascular collapse in the face of severe thrombocytopenia that initially had sort of a waxing and waning clinical syndrome. I think that's so helpful because we were already concerned for infections. And then all of a sudden, we can now view this case through that lens. And something that predisposed this patient to infections, though we named specifically the encapsulated organisms, but I bet all types of infection, is the fact that this patient doesn't have a spleen. And whenever you're approaching infections, and I'm going to try this because I heard Robbie do it once, you ask the question, are you dealing with an environmental organism or a organism that just exists on our skin? And I would argue that those organisms on the skin are stuff like staph and strep, and those are like common bugs that cause cellulitis. We aspirate, they can cause pneumonia. But this picture, using the time course and the exposures, it really pushes you away from a commensal organism and prioritizes an environmental organism. And when you're prioritizing an environmental organism, it's really what exists out in the environment. And approaching infectious disease, just putting it in buckets of like bacteria, fungi, parasites, and viruses. And a viral syndrome to wax and wane like this with, it's not that it's inconceivable. In fact, we had a case that Sammy Maddie, right? Sammy Maddie, I think, presented to us, if that's Sammy's last name. Remember the hantavirus, Robbie, and you picked up the thrombocytopenia with the marked pulmonary findings and the rat exposure. And hantavirus, but in this case, I'm prioritizing bacteria, and honestly, reflexively, when Ravi presented the additional data and looping in that severe thrombocytopenia and that rash, like, could this be a rickettsial organism? And rickettsial organisms would be a good fit for rash. They would be a good fit for myocarditis. They would be a good fit for this sort of waxing and waning. And the end stage without doxy is exactly what we're seeing unfold here. It's hard for me to imagine, this patient inhaling a spore in a fungus presenting in such a rip-roaring fashion. And also hard to imagine a parasite doing this as well. So it's really virus and bacteria. And because the spleen is removed and there's such a severe degree of thrombocytopenia, there's an AST, ALT, really prioritizes for me rickettsial infections, but also their cousins, because whenever you say rickettsia, you have to think of a few other organisms like leptospirosis. Now, leptospirosis, if there was any rat exposure, it can involve the liver, give a little bit of a bilirubin. It can involve the lung, and really through bleeding, and that's known as Weil's syndrome of lepto. But it's just not matching for me when Ravi's presenting. I'm more in that sort of doxy deficient state of rickettsia, coxiella, tularemia, and such. But let me pass it to the master at infectious diseases, because I know he's putting together, he's a brilliant mind, is calculating. And Ravi, break it down. I just called you Ravi. Ravi, break it down like we know you do.
Oh, Prof, don't do that to me. I will be honest with you. I think that a deep thrombocytopenia is such a powerful clue to an exogenous infection. It's almost a characteristic feature of many of them. But the reason I wasn't even suspecting this very rich travel history is for one reason that I think I should vocalize out loud, which is the vast majority of these exogenous, really cool infections do not involve the lungs. And most of these cases, if you just look back on the history of VMR, dengue fever, Ehrlichia, anaplasma, babesia, malaria, the lungs are relatively spared. And that's a very beautiful and very interesting feature of these zoonotic infections is they affect the brain, they affect the liver, they affect the kidney, but they tend to spare the lungs. And so that's why I was like, oh, okay, I wonder if this person has like pneumococcal bacteremia or some sort of pyogenic organism. And so the angle at which I can only supplement your beautiful conversation is just to like ask the question, how does the lung involvement help us here? And what filter does that help us apply? And I think that there's always a little bit of a tension because anybody who's very sick can get non-specific lung involvement in the form of ARDS. So we've seen it with babesia, we've seen it with malaria. And so I think the thing that I'm grappling with is this person sick enough to get ARDS? Or do they have a cardiopulmonary predominant manifestation of their potential zoonotic infection? And I think based on the intubation to a creatinine of 1.4 and the liver enzymes being normal, I think it's fair to at least do the thought exercise of which one of these exotic infections do have a prominent pulmonary signature. And I think hantavirus is one of them, though I think the exposure demographics here are not in keeping, as far as I know, with hantavirus, though this patient has that constellation of thrombocytopenia, hemoconcentration, and leukocytosis. So it's definitely possible, especially when you loop in the cardiac possibility. So I think hantavirus is definitely something worth testing for in this patient. The other big ones are the ones you mentioned: rickettsia, leptospirosis, and tularemia. And so, what would this do practically? I think you would probably not have to do much more than to add on doxycycline. But I'm trying to think it through. What else? You probably would have ceftriaxone on board. But honestly, I think the biggest takeaway that I would impart is lung diseases are relatively uncommon in tick-borne or zoonotic infections. And a short checklist of the ones that tend to do so are tularemia, lepto, Rocky Mountain or rickettsial organisms, and hantavirus, all of which you mentioned. And so I don't have anything to add to your conversation apart from just emphasizing most of the time these patients don't need to be intubated for their zoonotic infection.
Well, listen, it brings me great joy that you approve that message I sent that I learned from you. And you know, one organism I forgot to mention, but it really deserves mention, is Legionella. Because we just learned that Legionella, when you travel and you stay at hotels, the way their water system is set up, it promotes the growth of Legionella. I'm actually at a motel, not a hotel, because we're trying to save some money right now. I'm at a motel. And as I was like wiping my face with it, I was like, oh man, what's going on? Like, am I gonna get sick? Am I not gonna get sick? But yeah, the water supply, it's real. And thrombocytopenia, AST, ALT, ARDS, because oftentimes people get started on vancomycin, but they don't get that coverage of the atypical organisms. And something I've been thinking about more recently, and I know we're running short of time, so maybe we'll talk about it later, is we always talk about a doxy deficient state, but can we say in a azithromycin deficient state, or does it have to be a doxy deficient state? I'll leave that for your beautiful minds to ponder.
Rabih, I think he
Okay.
meant your
I was like, oh wow, the discussion is so rich. But I guess we're into the last leg of this case. So with the infectious disease on board, I think everybody pretty much has mentioned this. What was interesting when you think about rash, patient going into the mountains and hunting, this rash was a clue for Lyme's disease, and his Lyme's IgG, IgM came back positive. Now, it was interesting with him being so sick. I don't think we have seen with Lyme's somebody getting this ill unless the latter stages. But a blood smear review was done because, interestingly, he went down to Florida, and I mentioned Sarasota. Well, guess what? There was a outbreak of malaria there, and so doing a peripheral blood smear turned up positive for parasitic organisms, and the level of parasitemia was about 30%. And so further testing, malaria antigen PCR was negative, but Babesia was positive. So this was a case, again, I think we've seen this before on VMR, but just with the way the events unfolded, this is Lyme coexisting with Babesia. And just one thing interesting, I was mentioning, you were mentioning about the pulmonary process. His echo was normal. And what can happen with babesiosis, you don't get as much hemolysis as you get with malaria. But what happens with the RBCs, the red blood cells become very rigid with the parasites, and they tend to clump together. And because of that, usually they go and get stuck in the spleen, and the spleen gets enlarged. Like Reza had mentioned, the spleen was key in this. But this patient has no spleen. So where do they get stuck? They get stuck in the lungs. And when they get stuck in the lungs, you get ARDS, like Rabih had mentioned, and you can get non-cardiogenic pulmonary edema. So that could explain part of the pulmonary process this patient had. But with the splenectomy, guess what? He had major risk factors for a devastating infection. And regarding that mass, an MRI was done, and it was mentioned to be residual splenic tissue or something called splenosis. So it's just patches of residual spleen in that area. And that concludes the case. Well done, everyone.
Okay, I was just gonna say that's so good, Ravi. Such an instructive case. And it takes me right back to when I was in residency and sitting next to Harry Hollander, our program director. And Ravi, he said that, when the spleen is removed, these organisms, these parasites, they can really be rip-roaring. And that actually led to us, you remember that case of babesiosis at Hopkins in a patient who had sickle cell, and they basically auto-infarcted their spleen. They had fevers ongoing for several days. But yeah, what a and it also highlights the point that these organisms that are tick-borne travel together because they have one vehicle for infecting people. And so it's a great fit, the rash for Lyme, but then the robust presentation for Babesia and someone that has their spleen removed. Very instructive case. I loved it. Ravi?
I just love, yeah, this is so educational in so many ways. I don't never heard the pearl of the idea of what happens to those rigid blood cells when the spleen isn't there, and the fact that they crowd out the lungs is such a cool way of uploading that pearl. I really, really appreciate it. And I also appreciate you making the point that the finding of Lyme disease in a critically ill patient like this often doesn't mean the Lyme is causative. It just gives momentum to the hypothesis that the patient is in fact at high risk for zoonotic infection. So a point that Prof. Rez made so beautifully in many our previous cases of sexually transmitted infections traveling together, and so do zoonotic diseases. And so if some person has Lyme, yes, Lyme can cause a superficial infection with erythema migrans. It can cause some devastating neurologic and cardiac rhythm issues, but it doesn't cause somebody to get intubated. And so I think that the momentum to look for other causes shouldn't be halted by Lyme. It should be reinforced by that finding. And I think this case makes that point so beautifully. I also want to just close the loop on something that Prof. Rez said. I keep learning from you, Prof. Rez, not to close the door on a hemolytic process with a normal hemoglobin. And I think for all of you here to see a diagnosis of severe 30% parasitemia, Babesia, with a hemoglobin of 14 just keeps that fact on your toes. Hemolysis is a destructive process of red blood cells, but if your body is healthy, you can make just as many red blood cells as you're losing. And so you don't have to be anemic. So that was yet another really important point that came up in this case. I'm curious, Ravi, before we learn from Elena, what were the highlights for you, and what were the things that stuck with you learning wise?
I think just obtaining history. I think initially the way this case and the momentum of the case was just stabilizing the patient, but then after stabilizing the patient on the vent and putting a stop to the process, the hypoxemia and possible injury to the patient and end organ damage due to hypoxemia and circulatory collapse, we had time then to start thinking about what was happening and then continue. We usually get on the phone, contact family members, look on the electronic medical record to find any history. But then just with this somebody was able to contact the family and tell them the person is in the hospital, and then to come to the hospital and then get this history was very helpful. Otherwise, we're kind of like waiting. We sort of lost in the thick of this case, trying to figure out what was the impetus for this case or this presentation. But fantastic job. Yeah, I really appreciated you discussing the case and doing justice to the case. So fantastic learning points.
You're way too kind, Ravi. Way too kind. All righty. Last but not least, take us home, my friend.
Yeah, thank you so much, Ravi. What a fantastic case. I have to admit that I barely see my notes, so I will try to read them. So we have had a lot of different cases of shortness of breath and maybe some catecholamine surge on VMR. But what the hypoxemia actually does is that it localizes the lesion to an organ failure. So we have some issue with the heart, or we have some issue with the lung. So when we take an anatomic approach for hypoxemia, we look at whether the alveolus is at play, whether we have some filling with blood, pus, or water, or if there's some kind of collapse in the context of atelectasis. On the other hand, we can have an issue with the blood vessels. We can have, for example, shunting, we can have blocked blood vessels, or we can have, in rare instances, coagulopathy. And now on exam, how can we make progress? And Rabih shared with us that when we have a silent lung, this points us more towards a blood vessel issue. And also relative silence and disproportionate hemodynamic symptoms like hypotension or tachycardia can also point towards a vascular etiology. For example, when we have a patient with PE to cause hypoxemia, usually the hemodynamic imprint will be very apparent. When we have a hypoxemic patient, we should also look at the pulse oximetry because it should represent systole and diastole to really give us a clue that this is actually an accurate measurement. And if we have some doubt on that, we should definitely get that ABG. Reza also mentioned that we should not only focus on the lungs and the hearts with the catecholamine surge, but also on extrathoracic problems like thyrotoxicosis or pheochromocytoma. Of course, those are much more rare diseases. So generally, with an excessive sympathetic tone, we should think about intrinsic causes like catecholamine surge, an acute illness like we had in this patient, but also of extrinsic triggers. For example, withdrawal, especially of opioids or alcohol, or an intoxication of, for example, methamphetamine, something like that. So from the intrinsic side, we can ask, and Reza shared this with us, if the catecholamine surge is actually appropriate or if it's inappropriate, again, in the context of pheo or thyrotoxicosis. So in our patient, we learned that they suffered from an alcohol use disorder, and we were asking the question in this context, are we seeing the consequences of a withdrawal? Or is this potentially even masked by acute intoxication and it would actually be even worse? And what are the potential chronic consequences on the lungs or on the heart with alcohol use disorder? Reza then also shared with us that there are a variety of complications on patients who don't have a spleen. They're especially at risk for encapsulated organism like H. influenza, Neisseria, S. pneumo. But they can also have vascular problems like a portal vein thrombosis. We then learned from Rabih that the patient had also some kind of rash on the leg, and when we have a rash in general, we usually want to know, is this like a superficial thing? Is this an outside job like contact dermatitis or cellulitis? Or is this something that actually comes from within? We had other VMRs where when we had like a rash that was, for example, on the thorax, we would be more cautious in this instance because an inside job would be more possible. There are instances when we deviate from this rule, especially when the rash is very deep. To get an idea if the depth is if the rash is very deep, for example, in the context of ulcerative, nodular, vascular, like livedo, or purpuric rash. So there's a variety of skin-lung diseases, and if you're, for example, in Southeast Asia, you definitely want to think of melioidosis, which was not the case in this scenario. We then learned that the patient also had thrombocytopenia, and with thrombocytopenia, there's a variety of causes that we definitely don't want to miss, namely TMA, DIC, HIT, MAHA, and autoimmune hemolytic anemia. But in this context, we were mostly concerned that this is actually a bystander at the beginning because of the severe inflammation that was likely due to sepsis. But we will learn that actually we should always keep that in the back of our minds, that this could still be hemolysis. And then of course, in the context of splenectomy, we would be even more worried about thrombocytopenia because we would actually expect much higher levels of thrombocytes. In the end, we also learned again that we don't need to have a low hemoglobin to have hemolysis. In fact, if your body or your bone marrow is healthy, you can produce as much red blood cells as are being destructed. So in this inflamed patient with respiratory failure, to decide whether we are dealing with actually like a hyperacute heart or lung disease, a BNP can actually be a fantastic clue. But there are a variety of severe cardiac causes that need to be diagnosed within an hour, namely ACS, rapidly progressive pericardial effusion that could go into tamponade, but also endocarditis. We learned in the end that due to, the wife shared actually this, that the husband went on a camping trip before, and we learned that there was some kind of preceding illness to this. And the thrombocytopenia in this context, because we were worrying about, is this like a commensal organism, if this is infection, or is this an environmental or zoonotic organism? And thrombocytopenia is actually a great clue that this could be a bug from the outside. However, lungs are actually an untypical site of infection if this is a zoonotic organism. However, there are some that we should definitely worry about, namely hantavirus, rickettsial disease, leptospirosis, tularemia, but also Legionella. With the recent camping, we learned in the end that the patient was actually positive for Lyme disease. However, it is not usually a causative organism to cause this kind of picture, but predisposes to other zoonotic infections, which the patient indeed had. So the patient turned out to have parasitemia with Babesia, and in the absence of spleen, we learned from Ravi that with the parasites are not really cleared by the spleen, so they will just go everywhere, and they can go to the lungs and cause ARDS, as in this instance. Yeah, thank you so much. It was a lot of fun.
Elena, du machst so einen tollen Job. Superb.
Yeah,
Superb.
thank you so much. that was awesome. Thank you.
I was texting Robbie, and you can tell when someone's such a skilled teacher, like the way you were enunciating the outline of your teaching points. And I thought, would I be able to teach like that in any language? Even my mother language, which is Farsi? And the answer is absolutely not. So just kudos to you. Thank you for doing such a phenomenal job. I'll pass the mic to the two R's, the two capital R's, Rabi and Ravi, to close the session out.
I think Ravi should have the last word.
Okay, that's all, folks. Thank you, Reza Rabih, for discussing this case. Thank you, everybody. And Lena, fantastic teaching points. Absolute job well done. Have a good weekend. Oh, and tomorrow, for those applying for Match 2025, please do come. We have a special guest for the personal statement session. So for everybody that's applying, do not forget, Deborah has mentioned this, and do attend. Take care, everybody. Bye.